The face is, well, it's arguably the most complex architectural structure in the human body. And when blunt force trauma shatters that structure, it immediately threatens survival. Welcome to the deep dive.
Hello.
Today we are taking a foundational source, the blueprint of maxillofacial trauma, laid out in Bailey and Love's Short Practice of Surgery, and we're turning it into a high-yield, systematic knowledge map for you.
That's right. And today's mission is really tailored for you, the learner. Whether you're preparing for revision, walking into a high-stakes trauma rotation, or you just need to absorb that systematic approach to facial injury, we're here to provide the framework.
And this isn't just about spotting fractures, is it?
Not at all. It's about understanding the sequence, from the immediate life-saving maneuvers right through to the meticulous details of reconstruction.
And this knowledge is just so essential. Maxillofacial injuries are incredibly common. You see them from routine falls, sports accidents, right up to high-velocity RTAs and interpersonal violence.
But the immediate threat isn't the broken bones themselves.
No.
It's the anatomy. The facial skeleton is the support structure for your airway, your vision. So injuries here, they frequently compromise two of the most critical functions, maintaining a patent airway and preserving sight. That's why we approach this topic with extreme urgency.
Okay, let's unpack that absolute priority. As with all trauma, we start with ATLS guidelines, airway, breathing, circulation, the ABCs, but what specifically makes severe facial trauma such a unique, immediate danger to the airway?
The danger is really a combination of two things, mechanical collapse and incredibly rapid swelling.
Okay.
So imagine a severe midface impact. A huge energy transfer that can completely detach the maxilla from the skull base.
The whole upper jaw just breaks off.
And when that happens, the maxilla with the teeth and all the soft tissue gets displaced downwards and crucially backwards.
That posterior displacement sounds like a physical stopper in the throat.
It is. It's exactly that, especially in a patient lying on their back. It just drastically reduces the pharyngeal space.
And that's not all, is it? There are compounding factors.
Oh, absolutely. Now, compound that with a really common secondary injury, a bilateral fracture of the mandible.
So the lower jaw broken on both sides.
Right. And the mandible is the anchor for the tongue's muscles. So if it's broken on both sides, the tongue loses all its support and just collapses backwards.
So you got the maxilla coming back, the tongue coming back.
And you've got a catastrophic obstruction. And that's even before we talk about swelling.
Right. The body's inflammatory response is already kicking in.
Exactly. Even without that immediate mechanical collapse, these injuries cause massive rapid edema of the soft palate and the tongue. And that swelling can just close off any remaining space in minutes. It can turn a compromised airway into a total collapse, just like that.
Which requires decisive, zero-delay airway management. So if the team is prepping for, say, definitive intubation, what are the immediate bedside maneuvers you have to perform for some immediate relief?
Well, first, the team has to be ready for failure. That's rule one.
What do you mean?
It means you have the equipment for endotracheal intubation ready, but right next to it, you have the tools for a surgical airway. A needle, cricothyroidotomy kit, and emergency tracheostomy tray. Because if intubation fails from bleeding or just distorted anatomy, you have seconds to act.
And while that's being prepared,
You do these immediate, pretty dramatic maneuvers. If the patient is obtunded, less responsive from shock or a head injury, you can sometimes do a manual disimpaction of the maxilla.
you literally pull their face forward.
You literally grab the maxilla with your fingers and pull the entire midface forward. You're lifting it off the back wall of the pharynx.
And what about the tongue itself? If those mandibular anchors are gone, how do you manage that soft tissue obstacle?
You have to control the tongue. It's critical. You might use aggressive traction, maybe a big suture, or even a towel clip through the tongue, pulling it forward and just holding it there until you're stable.
And something that's often overlooked.
Suction, high volume suction. It has to be on and it has to be continuous. These are bloody, debris-filled airways. You've got to aggressively clear out blood, shattered teeth, bone fragments, or the patient's just going to aspirate it all.
Okay, so airway is being managed. The second immediate threat is catastrophic hemorrhage. Where does this torrential bleeding actually come from in facial trauma? It seems so internal and hard to get to.
It is. It's often hidden and absolutely life-threatening, especially in high-velocity trauma or deep penetrating wounds. In the midface, you're worried about the big vessels tucked away deep behind the bone.
Like the maxillary artery?
The maxillary artery, exactly. And also the pterygoid venous plexus, which is this very vascular, thin-walled network of veins. They're complex, they're inaccessible, and they bleed a lot.
And if the injury extends lower, into the neck.
Then you're dealing with major branches of the external carotid or tributaries of the internal jugular vein. Even the smaller facial vessels, there are so many of them, they can contribute significantly to total blood loss.
So how do you stop a bleed from an inaccessible network deep inside the nasal cavity? Digital pressure isn't really an option.
No, it's not. For those internal sources, especially if blood is just pouring down the pharynx, you have to apply internal pressure. So we use anterior and posterior nasal packs.
What does that involve?
These can be quite elaborate, like commercial inflatable balloon packs that press on the entire nasal lining. Or you can use basic tools like a large Foley urinary catheter.
A Foley catheter. That sounds like some improvised surgical genius. How on earth does that work?
It's actually very effective. You pass the catheter into the nose, right back into the nasopharynx, then you inflate the balloon with saline and pull it forward.
Ah, so the balloon wedges against the back opening in the nose.
Exactly. It acts as a posterior plug. Then you pack the front of the nose really tightly against it. This kind of sandwich technique creates enough pressure to tamponade bleeding from those deep sources, like branches of the maxillary artery.
Okay. Moving beyond the immediate ABCs, the source material really emphasizes two hidden dangers: the brain and vision. Why is the head injury concern so pronounced here?
It's because of the mechanism and, frankly, the demographics. Patients with facial injuries, especially from fights, are often intoxicated with alcohol or drugs.
And that can mask the symptoms.
Yes, it dramatically clouds the clinical picture. It can mask the neurological signs of a severe underlying head injury, a significant cerebral bleed. Their pain tolerance is up. Their mental status is already altered. It's a mess.
So the threshold for suspicion has to be almost zero.
Absolutely. You have to have an exceptionally low threshold for ordering a brain CT scan. You just have to rule out intracranial injury. And a quick tip, always remember to extend that imaging request to include the facial bones at the same time. It avoids a second scan later on.
And the other hidden urgency, the orbital threat. Midface trauma means sight-threatening injury until you prove otherwise.
That is the rule. And the most critical surgical emergency we have to identify is retrobulbar hemorrhage.
Let's clarify that. What is actually happening mechanically in a retrobulbar hemorrhage?
So the orbit is basically a rigid cone of bone. When trauma causes bleeding behind the eyeball in the retrobulbar space, that blood has nowhere to go. It can't expand.
So the pressure just builds and builds.
Rapidly. The pressure skyrockets inside this confined space, and that pressure compresses the central retinal artery and, most importantly, the optic nerve. If that compression is sustained, you get ischemia, and that leads to irreversible vision loss, blindness, in a matter of hours.
So what are the clinical signs we need to spot immediately?
You're looking for tense, painful proptosis. The eyeball is literally bulging forward. The patient will report their vision is rapidly decreasing, and they'll often lose their pupillary response to light.
And there's a key early sign.
Yes. A really key early sign, sometimes quite subtle, is the patient reporting an altered perception of the color red in that eye. This is a clinical diagnosis. You do not wait for imaging, you act.
And that action, the immediate sight-saving treatment, is a lateral canthotomy and cantholysis. Explain exactly what that procedure does at the bedside.
It's an immediate surgical maneuver you do right there, under local anesthetic. The canthotomy is a cut at the lateral corner of the eye. The cantholysis is then cutting the lateral canthal tendon, which is the tough band that holds the lower eyelid tight.
And by cutting that tendon,
You release the lower eyelid. You effectively open up the cone, increasing the available volume in the orbit. It decompresses the space, relieves that catastrophic pressure on the optic nerve, and hopefully saves the patient's sight.
So we've dealt with that acute life-threatening phase. Now we need to transition to diagnosis. And with the huge variety of facial injuries, you need a systematic language, a classification system, so the team can actually communicate and plan.
Absolutely. Classification gives you the structure to move from chaos to an organized plan. And we start with the basic vocabulary of the fracture itself.
Give us those basic descriptors.
Sure, we use standard terms. A simple fracture is just an isolated single break. A compound fracture is one that communicates with the outside world, either through the skin or the mucosa.
So it's an open fracture, basically. High infection risk.
Huge infection risk. Then you have comminuted, which means the bone is shattered into multiple fragments. A complicated fracture involves injury to a critical structure, like a nerve or a major blood vessel.
In green stick, I remember that from school.
Right. Common in children. It's where only one cortex of the bone breaks. And finally, a pathological fracture is one that occurs through bone that's already weak, maybe from a tumor. And then, of course, you have to describe the alignment. Undisplaced, minimally displaced, or significantly displaced.
So that describes the injury itself. Now for the geography. The sources organize the face vertically into thirds, which helps with that initial categorization.
This vertical map is essential for thinking about it. The upper face runs from the level of the corners of the eyes upwards, so your frontal bone, frontal sinus. The midface is that really complex area from your upper teeth up to the canthi. It includes the cheekbones, the nose, and the lower face is simple. It's the mandible and its teeth.
And since the midface is so anatomically dense, it needs even more division.
It does. We subdivide it into a central component. That's the naso-orbital ethmoidal, or NOE, complex, that really fragile bone around the nose and the inner eye, and a lateral component, which is the stronger zygomatico-maxillary complex, the cheekbone.
And orbital fractures can happen on their own.
They can, yeah. You can get isolated fractures of the floor, the walls, or the roof of the eye socket, but more often they're part of a larger fracture pattern.
Now, when these injuries cross the boundary into the skull, the term changes to craniofacial fracture.
Yes. A craniofacial fracture involves the facial skeleton and the skull, particularly the frontal or ethmoidal sinuses. The second you diagnose that, it becomes a joint case. Neurosurgery and maxillofacial have to work together because the risk of a dural tear, a brain bleed, or meningitis is just too high.
And then there's the ultimate level of severity, panfacial fractures.
That's the most catastrophic category. A panfacial fracture means you have bony injury at all three levels, upper, middle, and lower.
So the whole face is broken.
The whole face is shattered. It implies a massive transfer of energy, and it makes concurrent systemic injuries, head, chest, abdominal trauma, almost a certainty. It stops being a local surgical problem and becomes a major multi-system trauma resuscitation.
We also need to classify the soft tissue injuries, which dictates how you close them and the risk of contamination.
Right. And we classify those by mechanism. A laceration is usually from a crushing or blunt object, so you get these irregular bruised edges. An incised wound is from something sharp like glass, so you get clean, straight edges.
You have to identify the through-and-through wounds.
You must. These are wounds that communicate from the skin right through to the mucosa of the mouth or the nose.
Yeah.
And that dramatically increases the risk of bacterial contamination from, all the flora in the mouth.
Okay, the history and examination. This is where we systematically gather the information to build that surgical plan. For the learner listening, what are the history points that are absolute must-knows?
The mechanism of injury is a must-know. Was this a high-speed car crash? That suggests massive, complex comminution. Or was it a punch? That suggests more predictable zygomatic or mandibular patterns. Understanding the energy helps you predict the injuries you can't see yet.
And the general patient history is vital before any surgery.
Absolutely. You need to know their fitness for a general anesthetic. Their tetanus status is non-negotiable. If the wound is dirty, they get a booster. And you have to meticulously document all their medications, especially anticoagulants, antiplatelets, or steroids, which all affect clotting and healing.
Okay. Once that primary ABC survey is done, the secondary survey begins with a meticulous top-down examination.
And you proceed methodically. You start with the scalp, the back of the neck, the ears, looking for hematomas, step deformities. Then you move to the frontal view, assessing wounds for size, location, depth.
And there's a critical rule here about foreign bodies.
Yes, you remove large, obvious debris and dirt. But if you find large, penetrating fragments, a shard of glass, a knife blade, you leave them in situ.
You leave it in place. Why? What about infection?
Because you risk exsanguination. That foreign body might be tamponating a major vessel. If you pull it out at the bedside, you could have an immediate uncontrollable hemorrhage. They only come out in the operating theater where you have full vascular control and after imaging has shown you exactly where it is.
And a brief neurological check is needed here, with a special focus on the cervical spine.
Given the forces involved, the risk of a concurrent C-spine injury is high. So the neck stays protected until it's cleared radiologically, and then you do a focused cranial nerve check. If the midface is smashed, you check the facial nerve and trigeminal sensation. If the orbit's involved, you're immediately focused on vision and eye movements.
The eye exam is often the hardest part, right? Because of that immediate massive swelling. How do you even do a full orbital assessment when the eyes are swollen completely shut?
It takes patience and a gentle technique, but a full exam is mandatory. You have to assess globe position, visual acuity, check for double vision, measure the intercanthal distance, and test eye motility.
And how do you get those swollen lids open?
You use gentle tools to help. A bit of dry gauze, a cotton bud, or even a microbiology swab stick can be used to gently pull the lids apart. Sometimes just brief, gentle pressure on the swollen tissue can reduce the edema just enough for you to get a quick glimpse of the globe. You have to see it to clear it.
Okay, after inspection, we move to palpation, the physical search for bony asymmetry, tenderness, or a step deformity. This sequence should be automatic.
It should be a systematic path you trace. Start at the top, palpate the supraorbital ridge, move out to the lateral orbital wall, follow it down to the inferior orbital rim, then check the main body of the zygomatic bone. Next, you assess the nasal bones. Finally, you move to the TMJ and then the entire length of the mandible on both sides. Any step or abnormal mobility, you found a fracture.
And the oral cavity. It provides some vital clues, especially about the patient's bite.
A good look in the mouth is critical. You need good light and often aggressive suction to clear blood. You're looking for lacerations, bruising, hematomas, especially in the floor of the mouth, which can swell rapidly and threaten the airway.
And the patient's own report of their bite, their occlusion, is often the most sensitive diagnostic tool.
Absolutely. A key feature of a displaced maxillary or mandibular fracture is altered occlusion. The patient will tell you, "My teeth don't fit together, right?" They are incredibly sensitive to even a tiny change in their bite. Any change from their normal bite is a huge red flag for a displaced fracture.
When you're examining the teeth, what specific injuries do you need to categorize?
You need to note every tooth: present, absent, mobile. Injuries are classified as avulsed, knocked out, completely luxated, displaced, but still attached or fractured.
And we have to account for the aspiration risk of any missing teeth.
This is a golden rule in maxillofacial trauma. You account for every missing tooth or fragment. If it's not on the floor and it didn't come out of the mouth, it's been swallowed or, far more dangerously, aspirated. You must get a chest x-ray immediately to rule out aspiration. It's a non-negotiable step.
And finally, let's just quickly revisit the neurological impact of a lower face injury. We mentioned the inferior alveolar nerve.
Yes, a badly displaced mandibular fracture can shear or crush that nerve, which runs right inside the bone. So you check for numbness or altered sensation paresthesia in the lower lip and chin. That's the sensory area of the mental nerve. Documenting that pre-op is vital, so the clinical exam leads you, but imaging is your definitive map for surgery. And we use different imaging depending on what we suspect.
Let's start with the mandible. What are the mandatory views?
For any suspected mandibular fracture, you need two views: an orthopantomogram, or OPT, which is that panoramic view of the dental arches, and a posterior anterior, or PA, radiograph of the mandible.
And the rule is always 2 views at right angles. Why is that so critical here?
Because you will miss fractures otherwise. For example, a condylar fracture, a break in the neck of the jaw joint, can be really hard to see on a standard OPT because of all the overlapping bones. But the PA view can often show you the displacement or angulation of that condyle crystal clear. If you only get one view, you'll miss the second fracture.
And for the midface and zygoma?
For screening, we use occipitomental, or OM, radiographs, taken at 10 and 30 degrees. These views basically push the dense bones of the skull base out of the way so you can see the orbital rims and zygomatic arches more clearly.
And is there a key radiological hallmark that can confirm a zygomatic fracture even when there's too much swelling to feel anything?
Yes. The indirect but very reliable sign is opacification of the maxillary sinus on that side.
A fluid level.
Exactly. A fracture into the sinus causes bleeding, and that fluid collection shows up as a dense white or gray area on the film. It's a critical diagnostic shortcut.
And when do we have to escalate to the gold standard imaging?
A CT scan is the gold standard for any orbital injury, any Lefort fracture, panfacial trauma, or really any high-impact injury. And since you're often worried about a head injury anyway, the brain should always be included in that scan.
And the big advantage today is 3D reformatting.
It's a game changer. It allows the surgical team to manipulate the images, see the complex bony displacement in all 3 planes, and basically plan the entire reconstruction virtually before they even step into the operating room.
Okay, moving into specific injury management. Let's start with the soft tissues. Given the, aesthetic and functional importance of the face, timing is everything for closing lacerations.
It really is. The general principle is you treat soft tissue injuries clean and close them within 24 hours. If you delay past that, the risk of infection goes way up, and you get poorer healing and worse cosmetic outcomes.
Let's talk about the surgical details of that closure.
For uncomplicated wounds, you close in layers. You address the deep layers, like muscle, with resorbable sutures to take the tension off the skin. Then, for the superficial skin, the goal is a fine, precise approximation. We typically use fine, non-resorbable sutures like a 5-0 or 6-0, but in kids, you might use resorbable ones to avoid the trauma of taking them out.
The face has a reputation for healing remarkably well, doesn't it?
It does, and that's all thanks to its incredible blood supply. And that means we can be really conservative with debridement. You only remove tissue that is frankly necrotic, completely dead.
But if the wound is full of dirt or gravel,
Then it has to be rigorously cleaned and gently scrubbed.
Hmm.
If you don't, you get what's known as a dirt tattoo, where that debris gets permanently embedded in the skin. It leaves an indelible cosmetic defect.
and specific zones, like the lips and eyelids, require special care.
Oh, absolutely. Lacerations that cross the vermilion border of the lip, that sharp junction between the red lip and the skin, have to be approximated with almost obsessive precision. Otherwise, you get a noticeable notch deformity for life. Same goes for lacerations of the eyelid margins.
Let's move to two critical deep structures, the facial nerve and the parotid duct. How do you assess and manage injuries to them?
So facial nerve function has to be assessed routinely before you inject any local anesthetic that might confuse the picture. If you find an injury, repair is crucial. A good rule of thumb is that injuries located lateral to a vertical line drawn down from the outer corner of the eye have a better chance of successful repair under a microscope.
And the parotid duct, which carries saliva. How do you even know if that's been cut?
Its surface landmark is the middle third of a line from the tragus of the ear to the midpoint of the upper lip. If you suspect an injury, you look very closely at the wound for a telltale leak of clear, watery fluid saliva.
And to confirm it,
You cannulate the duct opening inside the mouth near the upper second molar and inject some methylene blue dye. If that blue dye appears in the external wound, your diagnosis is confirmed, and repair is required under high magnification over a temporary little cannula.
and what about high-risk wounds, like animal and human bites?
They require a mandatory protocol, high risk of polymicrobial infection. So they must be thoroughly clean, closed in layers, and you have to start prophylactic, broad-spectrum antibiotics. And for human bites, you should consider testing for HIV and hepatitis serology if it's a high-risk situation.
Okay, transitioning to the bone, the mandible, we mentioned that critical diagnostic pearl, the second break rule.
Yes. Because the mandible is this rigid U shape, force applied to one point often causes a secondary counter-coup fracture somewhere else. The most common condos are a break at the chin, the parasymphysis with a fracture at the ankle, or a chin fracture with a contralateral condylar fracture. So you always look for the second break.
Where are the inherent weak spots?
The three most frequent sites of fracture in order are the neck of the condyle, often from a fall onto the chin, the angle of the mandible, and the region of the mental foramen.
And how are most displaced fractures managed?
The vast majority of displaced mandibular fractures need open reduction and internal fixation, or ORAF. So you surgically access it, you reduce the fragments, and you fix them with titanium plates and screws. And you want to do that ideally within 24 to 48 hours.
Can you clarify the mechanics of fixation, load sharing versus load bearing? When do you use a light plate and when do you need a heavy reconstruction plate?
It all depends on the complexity of the break. Load sharing is for simple, non-comminuted fractures. You reduce the bone perfectly, and a light mini plate with monocortical screws that only grab one cortex of bone, is enough. The load of chewing is then shared between the healing bone and the plate.
And load bearing?
Load bearing is for when the bone is shattered or there's a gap. Here, a heavy reconstruction plate has to bear the entire functional load while the bone heals underneath. So you need heavy plates and long bicortical screws that engage both sides of the bone to get maximum stability.
Does the location of the fracture change the plating strategy?
It does. For the angular body, a single plate along the superior border, the tension side, is usually enough. But for the parasymphysis, the chin area, you often need two plates about 5 millimeters apart.
Why two?
Because the muscles of the chin generate significant torsional forces, twisting forces, that a single plate just can't resist. You'll risk hardware failure.
Condylar fractures often get special attention. When are they treated non-operatively?
Most undisplaced or minimally displaced condylar fractures are treated conservatively. That means a soft diet, maybe a few days of light elastic bands between the teeth, intermaxillary fixation or IMF to guide the bite, and then mobilization. Or IF is really only for specific complex breaks, like those with significant displacement or height loss.
And if you can't get to the operating room for a few days, what's the temporary fix for a patient with a grossly painful, displaced jaw?
For temporary relief, you just want to reduce the fragments and hold them stable. You can do that with temporary bridle wires or arch bars around the teeth to provide some provisional fixation. It reduces pain, stops more displacement, and lets the patient get some fluids in.
Okay, moving up to the midface, where blunt force creates these really specific fracture patterns. Let's start with the zygoma, the cheekbone, using that great structural analogy, the four-legged stool.
The four-legged stool analogy is perfect. It immediately explains the biomechanics. The zygoma connects to the face at 4 points: the zygomatic arch, the frontozygomatic process up top, the infraorbital rim in front, and the maxillary buttress below.
So when it gets hit, the fractures run along those legs.
Exactly. The force propagates along those 4 points, and you get this three-dimensional displacement.
Clinically, why is it often recommended to wait a week before definitively assessing a zygomatic fracture?
Because of the swelling, that area is incredibly vascular, and you get massive, rapid periorbital and cheek swelling. It completely obscures the underlying bone, so you can't accurately feel for a step deformity in the acute phase. If you wait about a week, the swelling subsides enough that you can accurately assess the asymmetry.
And what are the classic clinical signs you're looking for at that point?
Well, aside from the obvious asymmetry, you're looking for a palpable step deformity along the infraorbital rim. And crucially, you look for subconjunctival hemorrhage blood under the clear membrane of the eye that has no visible posterior limit.
What does that mean, no posterior limit?
It means the blood seems to disappear around the back of the eyeball. That's a huge clue that the fracture involves the orbital floor or walls.
So when does a zygomatic fracture absolutely need surgery?
The indications for ORIF are significant cosmetic deformity, an asymmetrical cheek, or persistent functional issues like double vision. A really important functional sign is restricted mouth opening.
How does a broken cheekbone stop you from opening your mouth?
It happens when the depressed zygoma fragment impinges on the coronoid process of the mandible. It physically blocks the jaw from opening fully.
If surgery is needed, what are the techniques?
For simple, isolated fractures, you might try a close reduction, like a Gillies lift through an incision in the temple. But for unstable or comminuted fractures, it's ORIF, using small, low-profile 1.5 millimeter titanium plates to fix the key buttresses.
Okay, next up, the maxilla, which
Yeah.
is defined by that highly influential Lefort classification system.
Yes, named for René Lefort, who, in this sort of macabre but essential study, figured out these predictable lines of weakness in the midface by, well, applying blunt force to cadaver heads.
Let's run through the three classic levels.
So Lefort asserts the lowest level, often called the floating palate. The fracture runs horizontally, basically separating the entire dental arch and hard palate from the rest of the face. Lefort 2 is the pyramidal fracture. It extends up from the back, crosses the inferior orbital rims, and meets at the nasal bridge, creating a pyramid shape. And Lefort 3 is the most devastating. It's called craniofacial disjunction, or the floating face.
So the whole face is separated from the skull.
The entire facial skeleton is separated from the skull base. The fracture runs through the zygomatic arches, the lateral orbital walls, and across the nasal bridge.
But in reality, these high-energy injuries are rarely such neat lines.
That's the clinical pearl, exactly. Lefort fractures are usually highly commended and often asymmetric. Management requires ORIF with 1.5 millimeter miniplates placed strategically along the strong vertical facial buttresses, and you have to be ready for the high bleeding risk from that pterygoid plexus.
Now, orbital fractures, we talked about the retrobulb or hemorrhage emergency, but what about the common blowout fractures?
A blowout fracture is the most common type. It's usually caused by an object larger than the orbital rim hitting the globe, like a baseball or a fist. The force is transmitted through the eyeball to the thin orbital walls, and they just shatter. The floor is the most common site.
What are the clinical signs that an orbital floor fracture is causing a real functional problem?
The key signs are all about muscle trapping. If orbital fat, or, more critically, the inferior rectus or inferior oblique muscles get trapped in that fracture line, the patient will have limited upward gaze and persistent double vision.
And there's a specific urgent pediatric version of this injury.
Yes, this is a critical distinction. It's the white eye blowout fracture in children. Because their bone is more elastic, it often acts like a trapdoor. It snaps open, traps the muscle, and snaps shut again.
And it's called white eye because there isn't much bruising.
Exactly. There is minimal visible hemorrhage, so it looks deceptively benign. But that tight entrapment of the muscle can trigger the oculocardiac reflex, which presents as a slow heart rate, nausea, and even syncope.
That sounds like a true surgical emergency.
It is an absolute urgency. Muscle necrosis can start within hours. These kids need immediate surgery to release that muscle and prevent permanent damage to their eye movement.
Let's talk about the late changes that might only show up weeks later.
Well, once that initial massive swelling goes down, you might start to see changes in the globe's position. Hypoglobus is when the eyeball sits lower than the other one, and anophthalmos is when the eyeball sinks backward into the socket because the broken walls have increased the total volume of the orbit.
So how do you decide who needs surgery for these later problems?
The main reasons to operate are persistent double vision or clinically significant anophthalmos. We use a specialized orthoptic assessment to differentiate between true muscle entrapment, which needs surgery, and simple muscle bruising or inflammation, which usually gets better on its own.
We have to reiterate the management of a retrobulbar hemorrhage. What's the sequence once you've made that diagnosis?
Once you see that tense proptosis, the decreasing vision, the pain, the fixed pupil, it's an immediate emergency. Step 1 is the bedside lateral canthotomy and cantholysis under local anesthetic. Step 2 is immediate medical management. Mannitol, acetazolamide, and high-dose steroids to reduce the pressure and protect the optic nerve. All right, rounding out our injury survey, we move to the frontal bone. An injury here signals high-force trauma and immediately puts you on alert for a neurological problem.
And frontal sinus fractures are classified based on which wall is broken.
Yes, it's based on whether the fracture involves the anterior table, the front wall, the posterior table, the back wall right next to the brain, or both, and crucially, whether the frontonasal duct that drains the sinus is damaged.
And you're looking for a CSF leak.
You're looking for CSF rhinorrhea, that clear fluid from the nose, and you confirm it with a basic-2 transferrin assay.
So what's the primary goal when managing these fractures?
The goal is to achieve a safe sinus. That means either restoring normal drainage or, if you have to, obliterating the sinus cavity completely to protect the intracranial structures and prevent chronic complications like meningitis or a mucocele.
What dictates surgery versus conservative management?
Minimally displaced fractures with an intact duct can often be managed conservatively, but you need to operate for significant displacement of the anterior table for cosmetic reasons, any damage to the duct, or any significant displacement of the posterior table.
And posterior table fractures sound like they must be a joint procedure.
They are. They mandate a joint neurosurgical and maxillofacial approach. Often the treatment involves cranialization of the sinus, removing all the lining, and permanently obliterating the cavity and the duct. And you need long-term follow-up with a CT scan at 6 to 12 months to make sure a mucocele hasn't formed.
Let's touch on the nasoethmoidal, or NOE complex, the nasal bridge.
Simple, isolated nasal fractures are often just managed a week later once the swelling goes down with a closed reduction. But NOE fractures are much more serious, high-force, comminuted injuries.
And what are the key clinical features we can't miss?
You'll see a depressed nasal bridge, maybe an upturned nasal tip, what's sometimes called a piggy nose. But the single most crucial diagnostic sign is telecanthus.
Telecanthus, can you clarify that? It's not just wide-set eyes.
No. Telecanthus is an increased distance between the inner corners of the eyelids, the medial canthi, while the distance between the pupils stays normal. It happens because the bone, where the medial canthal ligament attaches, has splayed apart. And if you don't reposition that ligament attachment perfectly during surgery, the patient is left with a severe, permanent cosmetic deformity.
And now the ultimate challenge, panfacial fractures. The management here is all about surgical sequencing.
Panfacial fractures are the peak of complexity. You stabilize the patient first and often delay the repair for a week. The whole principle is reconstruction using a systematic sequence to guide the shattered face back into its correct anatomical position.
And what is that recommended sequence?
We use the top-down and outside-in approach.
Sure.
You have to stabilize the most superior and lateral points first because they provide the reliable frame for the rest of the face.
So why top down, outside in?
Because you need to establish the correct facial width and projection before you can properly set the bite. So the sequence is, first, you fix the hundal bone and the zygomatic arches. That sets the width. Second, you repair the orbital rims and the NOE complex. Third, you fix the mandible. And only then, last, you repair the Le4 fractures and the orbital floor using that reconstructed mandible as your definitive guide to setting the correct bite.
And because setting the bite is the last critical step, a needle oral intubation is impossible during surgery.
Exactly. You need the teeth clear to wire them together temporarily. So for these complex repairs, you need either a surgical tracheostomy or a submental intubation, where the tube comes out through the floor of the mouth, giving the surgeon full access.
Okay, finally, let's briefly cover dental injuries.
Tooth fractures can range from simple enamel chips to those involving the dentin with pulp exposure, which is intensely painful and needs immediate attention.
And the handling of an avulsed tooth one knocked completely out has some very specific, life-altering rules.
This is a vital clinical pearl. A primary or deciduous tooth should never be reimplanted, but an avulsed adult permanent tooth should be reimplanted immediately into the socket. If you can't, you store it in milk, saliva, or saline and get to a dentist or maxillofacial specialist immediately. Time is everything.
And once it's back in?
It gets splinted to the adjacent teeth for about 2 weeks. The patient needs antibiotics, a chlorhexidine mouthwash, and a tetanus booster. And all dental injuries require follow-up with a dentist.
And as we stressed earlier, you always have to account for those missing fragments. Get a chest x-ray if you need to.
A critical safety step. It ties that immediate assessment right back to long-term health. Hashtag outro, synthesis, and final thought.
This has been a necessary deep dive into the systematic world of maxillofacial trauma, following that rigorous structure from Bailey and Love. We've really mapped the entire spectrum, from recognizing those mechanical threats to the airway, all the way to the immediate action needed for a retrobulbar hemorrhage.
We have. We established the framework of classification, from terms like committed to the reality of Lefort levels and the insight of the second break rule. We grounded complex surgical decisions in anatomy, emphasizing why you use load-sharing plates and why that pediatric white eye fracture is a true race against the clock.
I think the ultimate lesson for the learner preparing for this high-stakes environment is just that: systematic vigilance. These injuries demand a methodical, top-down approach, never forgetting that airway and sight are the immediate priorities that come before any fixation plan.
And we ended by talking about that complex surgical sequencing for panfacial fractures, the top-down, outside-in blueprint designed for perfect anatomical reduction. But here's the thought to mull over. When a patient is crashing in the resus bay with massive systemic injuries, unstable blood pressure, hypothermia, how do trauma teams successfully negotiate the tension between the ideal sequence of bony repair and the necessary speed of damage control surgery?
Right.
That constant real-time negotiation, changing the plan on the fly to prioritize the patient's physiology over achieving a perfect anatomical result, that clinical compromise, that is where the true art of trauma surgery